Thank you, Philip Boyd. I'm so happy to be here to present my lecture. So this topic is about a screening tool for FRAIL and sarcopenia. As you know, FRAIL and SARC-F is very famous, well known. And I think, but I would argue that SARC-F and FRAIL is good for clinical setting, but I'll argue that it will have some shortcomings for elderly in community dwelling, very shortcomings. So I will tackle about that. And on the right corner, you can see the symbol, which I am KI, Korean Frail Aging Post Study, so-called KPES. So I'm always proud of that. My wife drew this without any cost, so for us by study. So as to frailty screening, I'll explain a FRAIL questionnaire, and then I will introduce a frailty phenotype questionnaire. Our group just came up with. And lastly, I will show you pictorial scale, which is a new one. And as to the screening for sarcopenia, I will explain SARC-F questionnaire, and then I will introduce SARC-F cap circumference and also SARC-F and cap circumference combined, so-called SARC-Cap. And lastly, I will show you some new questionnaire in sarcopenia risk assessment. So FRAIL and SARC-F is too big a fortress to jump over for me. This fortress castle is named FRAIL and SARC-F, and the load is John Molly over there. So it's really provocative to jump over, but I'll jump over just a little bit. So yeah. Frailty. FRAIL questionnaire is recommended by International Academy on Nutrition and Aging, INA, for use in clinical practice. I will explain that, but FRAIL questionnaire is good for clinical settings, really, but has some shortcomings for community dwelling elderly for research survey. So, FRAIL questionnaire is developed by Dr. John Molly. I think he's a real genius. Although all the guests are genius, but so FRAIL stands for fatigue and resistance, and ambulation, and illness, and loss of weight. So FRAIL. As to fatigue, the question is tired. You feel tired. Be careful, it's not exhaustion. Tired, there's some difference. And as to resistance, difficulty walking up 10 steps without without resting. As to ambulation, difficulty walking several hundred yards. And illness, out of 11 illnesses, if 5 or more, increase the risk. So it means that it scores 1. And lastly, loss of weight, 5% per year. Compared to the free phenotype frailty, so I'm on side of the free side. So it is made of exhaustion, weakness, slow gait, and low activity, and weight loss. The exhaustion is made of 2 questions, right? I feel that everything I did was an effort, or I could not get going. And weakness, using hand grip strength, and slow gait, using gait speed. And low activity, we measure some questionnaire and calculating calories spent per week. So it is hard to measure gait speed and grip strength, and also you should calculate calorie with using some questionnaire. So genius John Molly developed this simple questionnaire for us. But I think, as I told you, that there are some shortcomings for to use elderly for community dwelling. Because if, for example, illness, 5 or more out of 11 diseases, the prevalence of 5 or more of those who had, in original research article for community dwelling elderly from Chang Won Won, it was just 2.1%. In community dwelling elderly, the prevalence of 5 or more old disease is very low. I'm sure that it will be very high in clinical setting, but in community dwelling it's low. Based on my CAPEX data, community dwelling elderly, that's 0.3%. It's very low. So I think it is good for hospital, clinical setting, but it may not go big for community setting. And it adopted tiredness. I think it's not the same with exhaustion. Tiredness is common. I think everybody feels tired, but exhaustion is a little more hard one. And surrogate, it asks about difficulty walking several hundred yards. I think it's already vague. So in Korea, it was translated in 300 meters. But I try to confirm whether this is good or not. So I'll show you that later. So overall, I think this does not represent the predicted phenotype. So when you check the sensitivity and specificity against the freed phenotype based on KPX method code study, sensitivity is a little low, 55%. Sensitivity is good, but a little low in sensitivity. So I and my group try to develop a screening questionnaire representing freed phenotype. So, I want to get some new questionnaire which will well represent in the free phenotype for community dwelling elderly. So because if we develop, we can use for community health service as a research, or primary care, or for the public person elderly to increase the self-awareness of frailty, self-checkup. So we, as I told you, we developed frailty phenotype questionnaire, FPQ. Is it just accepted by Chang? Is it right? So frailty phenotype questionnaire we developed made of 5 items: fatigue, resistance, ambulation, and inactivity. So we try to follow the original in the free model instead of illness and loss of weight. As to the fatigue, we chose actually the original in the 3D model as 2 questions, but we just adapted just 1 question. I've explained that. And resistance is the same as FRAIL, difficulty walking 10 steps. And ambulation is another one. We adopted difficulty walking 1 lap of a playground track, 500 meters. And inactivity, you participate in moderate or vigorous physical activity. If either of them, it increases the risk score, so scores 1. And loss of weight is similar to the same. Why I did choose just one of the 40 exhaustion questionnaire of in the free original model? Because when you look at the response based on the CAPEX code study, the number 1 question is dominating. Number 2 questionnaire response is just a little additive. So almost 850 respond yes to the first question. That is, well, everything I did was an effort in the last week. But for the second question, just a little additive. So for simple simplify. We just adapted the first one question. Weakness is the same with the FRAIL, because we check that, compare with the low grade strength, we compared difficulty 10-step walking or lifting and carrying 10 pounds. This is from the SARC-F questionnaire. Actually, kappa is better in lifting 10 pounds, but the sensitivity is low because we want to use this as screening, so we need a higher sensitivity. So balancing sensitivity and specificity, we chose the first one, 10-step chair climb-up. And third one, for ambulation. So compared to the low gate speed, we compared 4 questions. Difficulty walking 100 meters, 300 meters, and 400 meters is some explanation. Walking 1 lap of track and supplement with 400 meters. And lastly, walking crosswalk during green light. So as you see here, walking 1 lap of track 400 meters was the best. Kappa and sensitivity. Even though sensitivity was low, but we tried to balancing and sensitivity and specificity. And for the low physical activity, we compared many combinations of moderate, vigorous, or mild physical activity, and also sedentary time, more than 9 hours. So we found that moderate to vigorous, either to moderate to vigorous physical activity means it risks the risk, so we score 1. So you can see the sensitivity almost 90%, and specificity 67%. So altogether, we compare with the FRAIL phenotype. So we found that the total FRAIL phenotype questionnaire score with cutoff 3, the sensitivity was 81% and specificity 82%. So it is not bad. So we submitted to JAMDA, and we got mail that it was accepted, but we are under last editing state. But very coincidentally, we found that the almost similar paper was accepted and in press now. The title is Development of FRAIL Phenotype Questionnaire, who you see in common building order. It's from Japanese groups. Believe me, I haven't ever met them. I haven't talked about this study. We haven't put the posters ever, never. and in the same JAMDA journal. So actually, under review, we proposed this my article paper on the name of the same one, really, FRAIL Phenotype Questionnaire, FPQ. This is the original our proposal, but reviewer says please change the title, so we changed to FRAIL Phenotype Questionnaire. I think this article may influence our changing the title. Anyway, the contents is a little different. For the ambulation, it questions of 1 kilometer, 1,000 meters, and walk 1 hour. So it's a little different. And for FRAIL screening, there is some new and interesting questionnaire. I mean, it's a picture graph. So it is called Pictorial Fit-FRAIL Scale. It's made by RAG, and it's RAG's groups in Canada. So many graphic designers was involved in this study, and the 14 items was included in this Victoria Pittsburgh scale. So, for example, mood and number of meditations. I think this 5. I think it's more than 7. I think, and mobility and function. Function is kind of ADL. So it's very interesting to look into each one. It's very, very interesting. And balance. And social connections. And daytime tiredness. And memory. And vision, hearing, pain. And 12 is weight loss. And 13 is aggression. And lastly, blood control. Yeah. For example, blood control is okay. Small wedding, small wedding, large wedding. Yeah. So it's very well-designed graphic. So they say that pictorial Pittsburgh scale is feasible for people with communication issues, including dementia, or people with limited health literacy, who have never gone to primary school, or language barriers from other countries. So, and also, it doesn't need any geriatric training. It needs any geriatric training. Simple for anyone. And the total score is 43. 43 means severely frail. So I moved to sarcopenia. So first one is again SARC-F. So it stands for strength, assistance in walking, and rise from chair, and climb stairs, and force. So as to strength, it adopts about difficulty in lifting and carrying 10 pounds. 10 pounds. And assist walking or rise from chair, the question is difficulty walking across a room. And this is difficulty transferring from a chair to bed. This question included in SARC-F. So I think it's very good for clinical inpatients. Almost inpatients have problem in this way. But for ambulatory community dwelling elderly, they do well these items. Do you agree with that? Again, genius, Dr. Chang Won Won. Yeah. He's testing himself on his speed for you. SARC-F is well validated even in other countries, including me. So GNU group showed that they are very valid, but low sensitivity. In this study, sensitivity was for sarcopenia. Anyway, sensitivity is around 5%, and specificity around 98% in men. In women, is similar. So specificity is very nice, but sensitivity is a little low. So I say that SARC-F some shortcomings for community dwelling elderly. Yeah, again, it's good for clinical settings, but for community dwelling elderly, it's a little shortcomings. So I think SARC-F is good to severe sarcopenia, severe disabled men. But again, it's not enough for my sarcopenia community ambulatory persons. Because when you look at, again, these two questions, you can imagine why. And we translated this questionnaire and then we get published in JAMDA. And when we translated 10 pounds, in Korea we use just kilograms, so it goes to 4.5 kilograms. So very big and very understand how much it is. So we tried to provide some examples. So I looked into the internet. So it's a similar weighting objects. What will be around 4.5 kilograms out of the 4 items? So 1 sack of rice is 10 kilograms. 4 months baby, 7 kilograms. It's more obese, but anyway. And 9 Korean pear box. Pear is a little big, so it is about 4.5 kilograms. And third year high school backpack was also 4.5 kilograms. But as you know, high school backpack, Korean students study very hard. So many books, whether or not to read that or not. Anyway, but it depends on the student performance. Some students may have less. So we chose this more standard 9 Korean pear box for this question. So this is the Korean version and translated in English. So as you can see, as to the strength, we adopt difficulty, lifting and moving 4.5 kilograms, for example, a box of 9 gram pears. So like this, we translate and validate it. So as to compare with sarcopenia, sensitivity was around 16% in men, and specificity was around 98%. So it is similar as in genus report, the low sensitivity, but very high specificity. And then calf circumference. Calf circumference is not a questionnaire, but the next time I will show you the SARC-F plus calf circumference, so-called SARC-F is a little better than just SARC-F. So I should introduce calf loss. Calf circumference is good because it presents skeletal muscle mass well and predicts well physical performance, as you know. So Francisco Landy published this article in 2014. He says that calf circumference is well associated with walking speed and hand grip strength. And from Japan, Shinya Ishiguro published, and they compare the thigh circumference, calf, and upper arm circumference. So for muscle mass, grip strength, and usual gait speed, the best one was this calf circumference. Compared to thigh or upper arm, calf circumference was mostly related with muscle mass and strength and gait speed. Not thigh circumference, calf was the best. So our group also look at whether the calf circumference is good screening for sarcopenia in Korea based on the KPEX core study. So we found that the validity compared to sarcopenia is very nice. So in men, AUC was 0.82, and female is a little less, but still 0.72. So it's very nice. The CC, calf circumference, is good screening marker for sarcopenia in community-driven elderly. So, but sometimes we may think that we may worry about reliability, repeatability. I found that we use this table line, but you can find online the health-o-meter is a digital temperature cap, and increase automatically the maximum cap size. And before moving to SARC-F, I will stress something that cap circumference. So we know that the largest area of the cap is to measure, but there has been no standard recommendations, left or right, standing or sitting. Someone recommends that on the left-handed person, measure to right side. So we checked that which one is best. This is another study done by China. They compared between standing and spine for inpatients. Inpatients may have many edema, many fluid in water in leg. So they found that standing cap circumference in standing position is larger than when we measure in spine position. Why? I think they have much edema. They may have some heart failure, renal failure, and bed lying all the time. So edema makes, because when you stand up, water comes to the leg, and it looks like the measure have circumference larger than as it is. I think so. But how about ambulatory community dwelling elderly? We checked that based on the CAPEX core data. So we found that left standing is the shortest compared to the right or standing, sitting. So left side and standing is the smallest measure out of four combinations. Okay? So it's a significantly different. And even in left-handed, still left, not right, left standing was the smallest measure of cap. So no matter what, left or right hand dominant, I think left is the smallest and standing will be the smallest. When compared with the sarcopenia, with four combination of standing or left or right, the AUC was the best on the left standing. The left standing measures the smallest and seems to be the best for screening for sarcopenia. Even though the difference is not so big, but it seems to be the best. So CC, cap circumference, is better than thigh or upper arm because calf is easier to find the largest one because there are some belly, some bump. But thigh is not easy to the largest one because it's smooth. It's like a cylinder, so you cannot find the largest one. Okay? Some researchers recommend halfway between knee joint and great trochanter, but the halfway is not the largest one. That's the problem in terms of the thigh circumference. And upper arm, I think it's more likely to be an indicator of obesity, fat, rather than sarcopenia. And then, how about combining SARC-F and cap circumference, so-called SARC-F? This is studied in China in ambulatory community dwelling elderly. And how do you score? So SARC-F is total score is 10, and cap circumference is low. It scores 10. They think that it's very important. And it's good, 0, just 0. So total score will be almost 20. And cutoff point is 11. And compared with the sarcopenia, they found that sensitivity with SARC-F just 30%, but SARC-F is almost doubled. Sensitivities go up. and specificity or little decrement. So from 98% to 94%. So we can say that SARC-F increased modestly sensitivity, but a little decrement, decrease in specificity. And lastly, this is mini sarcopenia risk assessment, MSRA-5. So it is developed by Rossi, it's from Italy. So it's made up of 5 items of general and dietary. They think that dietary is very important component. And scoring, weighting, was done by arbitrary, by consensus of the researchers. And the questionnaire is this. So age, more than 70, hospitalization, and activity. Activity is asking able to walk 1,000 meters, 1 kilometer. And you eat 3 meals per day regularly, and weight loss. And out of 45 out of total 55, the sensitivity for sarcopenia was 0.8 and specificity and 0.6. So it's good, it's good. And actually they had 7 items and 5 items. 5 items, also 2 additional 7 items. Actually, 5 items was much better than 7 items, so I introduced just 5 items. And China, they translate and validate again, and they found that MSRA-5 has a high sensitivity, over 90%, and high specificity, 70%. Compared to the original study, it's much higher sensitivity, specificity. I think the sarcopenia prevalence in this study group was very high, almost 20%. So that's why the sensitivity and specificity was higher than the original article. The summary, FRAIL questionnaire has some shortcomings to use for community dwelling elderly. And we developed a FRAIL phenotype questionnaire. It could be a good questionnaire, especially to represent FRAIL phenotype in community dwelling elderly. And pictorial scale, very good for elderly with limited health literacy, but we need more study. As to sarcopenia, SARC-F also has some shortcomings to use for community dwelling elderly. And cap circumference is good screening for sarcopenia and was function. And SARC-F increased sensitivity modestly, but decreased specificity a little compared with SARC-F. Lastly, MSRA, mini sarcopenia risk assessment, is a new screen tool to be studied in many settings across the world. This is the end, and I'd like to give thanks to all CAPEX members, CAPEX research members, and especially these 2 beautiful women helped me to make an article and publish it, Professor Miji Kim and Dr. Sunyoung Kim. So, very compromised. So, Miji Kim and Sunyoung Kim. Yep. And also many members, and I should introduce Yunhan Lee. He's a co-PI. Yunhan Lee, Dr. Yeah, over there, he's a co-PI. So that's our CAPEX member. That is all, and thank you for your listening. Thanks so much.
Now, may I ask Chang Won first thing about this calf circumference? It's becoming now an interesting topic where it's an easily measurable item, and you are suggesting this as a screener for community dwelling elderly as a way of picking up sarcopenia. We still need some measure, using a tape or a health meter, but I was just listening to Dr. Alfonso and Jean-Pierre, and he said, why don't you use, as Ijima suggested, just your hands, and putting your hands at the apex of your calf muscles as you sit down, as a way of screening. So what do you think of that? The Japanese, again, have an idea that maybe make it so simple.
Yes, very tricky question. So, but unfortunately, we don't have any research using this hand ring, finger ring. So I think it's very nice. So I measure myself, my finger ring is almost 32 centimeters. It is almost the same as we recommend as a cutoff. But we need more research, and and also you need some variation in some finger ring individually. So that will be something we should look for whether it's okay. So we need more research, but I think it's very nice.
There's a presentation on that later on today. It's called the well, there's a name for that, I can't remember now. Yeah, you can't be.
So my name is Kaji Ijima from the University of Tokyo. So I also fingerling test has sometimes tricky, but so I know I believe so it is better using a fingerling test. So I believe so, it is better to it is better to raise early awareness to the importance of sarcopenia prevention. Now, so I agree. So this measurement of CC is better rather than fingerling test. But so in the community setting, so very fast screening through fingerling test.
I mean, just to continue this, you see, you have to use your own fingers for your own calf, right? You can't use somebody else's fingers for their calf, right?
So this can be a at-home examination, like a self-examination of your breast or whatever. You can use your way of actually screening yourself, whether you need to see the doctor or not, which may reduce all these requirements for health screening in a way. Good, thank you. So, any other questions? Aoyong, anything? I'm singling out the Hong Kong people. In case you plan.
Discussing with my colleague beside me about why not adding grip strength instrument to SARC-F, because grip strength instrument, dynamometer is quite widely available. It is could be more reliable than tape measurement. Of course, it is not always available, but now it's becoming more and more available nowadays. This is my comment.
Yeah, I mean, I think if we say that sarcopenia or frailty, for that matter, is a public health problem, and there are lots of old people, there are many different levels of screening. But clearly, if you add objective measures to questions by themselves, the sensitivity is going to increase. So that the whole thing is, what can you do in your community at the lowest level? Probably, questions has a place. Grip strength, all these things require equipment, and you have to standardize and so on. But at a higher level, obviously, grip strength measurements are going to be relevant. So we're talking at different levels for everybody, and then increasingly high accuracy. I think this is a perspective that is important, because otherwise, you can continue to discuss low sensitivity, high specificity, And you can continue this discussion, but I think it's really important to anchor it on what setting, not just hospital and community, but what level of community, at the family physician's level, or what. And then, most important is, what are you going to do with it when you found something abnormal? Because if you can't do anything, it's total waste of time. So in the UK, they have a very good general practitioner system, national health care system, and they use computerized consultation, and so they can construct a frailty index, the EFI, so using a whole lot of bloods and whatever. So then you can say, well, some people are frail, some people are not. But then I have yet to see what the GPs are doing about it, because the GPs practice in the practice, the doctor, nurse, patient, and they have 7 minutes for consultation. So there's a whole lot of chronic disease and drugs they have to look after. There's no community backup. They haven't linked it to what are you going to do every day in the community. It's no good telling people to do exercise. It doesn't work.
Well, Jean, you have to show the way, Jean, because I think in Hong Kong you've got a whole system, I think, in place in at least one center, so you can show the example that may be applicable for the whole system elsewhere.
Yeah, I think the knowledge transfer is very important. Once people in the community get how important this is, they really approach it in a very practical way. So they oh, what can I do for my members? And they're very keen to learn what activities are organized. And this is what you've got to stimulate, because the centers is there already. Instead of just playing mahjong, you know, they can do other things.
Question from Rashma Merchant.
I do need to echo what Jean said pertaining to Singapore. I think really whatever screening tool you're using depends whether you're using for your 2,000 population, your numbers. Are you using for 200,000 or are you using for 400,000? And actually similarly, who is going to be doing the assessment? If you really want to scale and sustain it, you need to train volunteers. You need to train peer leaders. And you need something really simple for them to skim off the top 30, 40, 50%, for the minority to actually go to whoever or wherever they need to go to. So it really, whatever tool we use depends who's going to be doing it. What's the outcome? What are you looking at? You know, how are you going to close the loop? At which level? So again, I do echo what Jean just said as well. Thank you.
So I forgot to mention the application of technology. If you measure things, you can't capture it. You can't use an automated system. And the automated system is really very powerful in covering large numbers of people. So when we used our thing, we kind of covered about 2,000 people in 1 month. Now if you conduct epidemiological study, you're never going to cover that in such a short time.
John, you're allowed to speak.
No, I think the reality is, first of all, what Jean does is what we're doing, what Rishma is doing in Singapore. I don't think it really matters what screens you need. It would be nice if we could all agree that any screen that has some sort of specificity is a good screen, because basically you want GPs and the health professionals to do it. The purpose of both of these, that when I developed the original ones, was the words were nice, so it made sense to the GP. And secondly, they both took 15 minutes to do it. I'm very lazy, and more than 15 minutes would have killed me if I had to do it. I realize that you can go on and perfect them, and each of them are slightly different. And I've told people to use in their communities when they're doing it, whatever words they think fit for their community, because in the United States, walking 1 block is a long way. That's what's in the original one. So for Americans, it works pretty well in the United States, but it would be changed wherever you go. But the important thing is, as Jean has done, as Rishma is doing, is to be able to turn around and say, if you do this, and it's positive, do something. It's no use screening and saying, well, I've got an even better screening test, but then I haven't done anything. And what I'll say tomorrow, because I'm supposed to say so you don't have to come tomorrow, is what is the future? The future, I think, is to take these tests and see if you put people into treatment programs, which are exercise and a bit more for frail people. By the way, because you took illness out, illness is there to pick up extra drugs. We know that in old people, e-prescribing is very important, and that was a proxy for finding out who would have more drugs. And so when we start to look at how to treat them, the illnesses is look at these prescribing, and that's its purpose more than anything else. But you've got to have an algorithm to follow through. And I think that's the piece that is so important. Jean has done it very well in Perry County and in one of our inner city programs, and in Kansas City. We're now doing this extraordinarily well at getting people to do it and follow through without having a geriatrician sitting there and saying, do it. You know, it also says that there's some people who are so sick that they should go to a geriatrician if you can find one. In the United States, we've got so few geriatricians now, and they're disappearing every year, that quite honestly, you're going to have other people to do it. So I think it's what you do with the screens. I'm not certain it matters what screen you do. I think we will go on doing it, and I'm always happy to see that people have better screens, because the more better screens, still they will use FRAIL and SARC-F, and I will feel happy. I'm not a genius, because if I was a genius, I would never have done something as stupid as this. Okay, so just recognize that these are simple things, but the whole point behind them, and what I want is that people screen everybody in the community, both for cognitive function, so we've got the whole rapid geriatric assessment, for the anorexia, for the sarcopenia, and for FRAIL. And I think if you do that, you do extraordinarily well. And I used cough circumference for years. Cough circumference actually correlates pretty well with DEXA. And that's been out there for years. I gave a talk in Brazil last year, and I just showed you only have to do cough circumference because they've got no DEXAs in most of the parts of Brazil. So do cough circumference, it works about as well. So lots of things work about as well. But if you do nothing with them, none of them work. So screening is great for epidemiology, it's great for us writing papers, but we have to take the step forward. And all of the people at the screening have to say, well, if you screen, are you going to treat these people, or are you going to at least do a full European workup or an Asian workup for sarcopenia? It's not going to happen in the small rural areas because most of the time they don't have the instruments available. And if you go to Malaysia and places, it's going to get harder and harder. So you've got to say, can we do simple things and can we make a difference with them? If we can, it's worthwhile. And Gina, I think, has shown beautifully you can. I mean, not everybody has a jockey club, Gina. If we had a jockey club, I would have it all over the United States by now. But they are very supportive of this sort of thing. But I think we're going to have to do that and show that you make a difference. We all know exercise makes a difference. Okay, so it's not a big thing. It's saying, here is something where the physicians don't say to you, go and do it. And whether it's cough circumference or it's any of these screens, I don't think it matters. But you've got to say, go do it. It's because you're showing that you are in trouble, and we have data to say that you're going to lose care. I mean, that's really what I think we're doing. But I'm not being totally fair, and that's my talk for tomorrow, so I will not come tomorrow and sleep in. Okay, thank you.
Thank you, John. It looks like you've summarized the whole thing in stating that you have to stratify your approach depending on what you're dealing with. I mean, which cohort you're dealing with. Whether you're dealing with the community dwelling, the primary care level, or hospital-based level, and the complexity of which you will, of course, increase as you go further down the line. So, I mean, the main item that we have talked about this second session is basically about identifying at the community level. And I think we've got two great speakers here who've actually identified how we can, there are various approaches to it. And Jean has actually suggested some interventions that have worked in Hong Kong, and maybe we can apply it elsewhere in the world. No last comments? Any last words before I... Oh, there is a last word there.
This is Michelle Chang from Taiwan. First of all, I want to thank for all the speakers, and I do agree that as a geriatrician, community geriatrician, we're now facing a challenge is we need something simple enough for our non-geriatric colleagues to be able to help us to do the screening. We also want to have the we have to have our role as a geriatricians, that be able to do something more than just offer lifestyle advice like everyone else can do. So with all the research that we've done in the past, at the moment I'm a bit struggle to know what's the referral point for our colleagues to activate the further investigation like we will do for audiologists. In the community, a lot of the suggestions we gave echo what Dr. Li Jiaming mentioned yesterday. We identified 10 problems with the individuals in the community. There's no way we can offer 10 pathways right at the beginning. It's either resource waste efficient, and also it can be quite stressful for that individual. So in my practice, I start to strategy my advisors. So I start with something really simple and test it for 2 weeks. If they can adhere to the suggestions, then I start opening up other doors for them. I don't know what the other expertise in terms of practice to sort of strategic our advice in the sort of treating the community patients. Thank you.
Well, I think the point is, I know the geriatricians are important, but we're not the center of the universe, right? So you're using a perspective that you have to be responsible for everything. But what I'm saying is, you have to do the public education so everybody knows why this is important, doing various things. And the algorithm is not for the doctors. The algorithm is for the carers, the old people themselves, to guide them to a certain pathway before they even get to a doctor. But I think geriatrician is very important in highlighting this issue, because if you talk to ordinary family doctors, they don't understand what you're talking about. They're still into diabetes, hypertension and stuff. I mean, sarcopenia, frailty, what's that? Why do you want to know? So I think geriatricians have a very important role in advocacy, but you're not doing everything yourself.
That's an excellent point, Jean. I think we really have to realize that one of the aims of a geriatrician is actually to prioritize and empower the elderly to do self-care. I think empowering is important. You don't want to mollycoddle them until they get into the coffin. So I think with that, it's just about time for lunch. I think you have 1 hour to have some food and then refresh your brain afterwards. Thank you very much to the speakers.